pleasure to introduce next speaker. I can see Henry is in the panel. And I cannot imagine someone better to talk about intraventricular anatomy than the president of the International Federation of Neuroendoscopy. So Henry, thanks so much for joining us. It's your turn.
Yes, thank you for the kind invitation. It's a great pleasure to speak here on an event of the WFNS Anatomy Committee. And I thank Imad especially and Vlad for inviting me. Can you hear me? I have some problems with the internet connection, I guess, or is it okay?
We can hear you properly.
We can hear you.
All right. So I have basic stuff. I was a little bit concerned I missed the topic because I thought it's anatomy and everybody is talking about cases and shows treatment paths and so on. So I have just simple anatomy. Imad, is that okay?
It's okay. There is always next time.
Okay, so I will talk about intraventricular endoscopy. That is very important for everybody who is dealing with endoscopic cases, of course. Sometimes it's very difficult to get orientation when we have pathological conditions, such after inflammation or after bleeding, so on. So this is a ventricular system. Everybody is knowing that the frontal horn, the central part, the occipital horn, and the temporal horn of the lateral ventricles. Then we have a foramen of Monro going to the third ventricle, going through the aqueduct to the fourth ventricle. And all these compartments can be approached with an endoscope, especially if they are dilated. So I just want to show you some endoscopic images taken by these diagnostic scopes. They have 0 degree, 30 degree, and 45 degrees. The diameter is 3.3 millimeters. And we have an HD camera to get the best quality which is currently available. And you see this is an endoscopic view into a craniopharyngioma cyst, and you can really see the erythrocytes going through the blood vessels. Such kind of high resolution you can get with an HD camera, and also the magnification if you have a good endoscope. So still so far, although we have chip-on-the-tip technology available today, the best quality is still with a rod lens endoscope, which is attached to a HD or 4K camera. So first we go to the lateral ventricle. The endoscope is inserted into the lateral ventricle via a precoronal borehole, what we use for ETV. And we have a 0 degree scope. And that is the usual anatomy, what you can see. Here you see the fornix, the septal vein, thalamostriate vein has a side branch from the head of the choroid nucleus, so the caudate vein. And here you have the choroidal vein, which is running with the choroid plexus. And this is the foramen of Monro. When we look a little bit to the left, we see the septum pellucidum. Sometimes we have a severe atrophy with holes in the septum and only the vessels remain, typical sign of a chronic intracranial hypertension. And sometimes there is no septum and we have a cyclops ventricle. That means it's just one ventricle without a septum pellucidum, and you see the fornices running free through the ventricle. And here you see the mesa intermedia. This is called plexus and a very large thalamostriate vein. It's another case where the septum is missing and you see the fornix running here, and this is one foramen and this is the other foramen. Then we use the 30 degree endoscope and we look in an anterior direction, and you see there's no choroid plexus. When you go with an endoscope into the ventricles and you do not see choroid plexus, usually you are in the anterior horn. And here you see the white structure. Here is the corpus callosum, and the gray one is the head of the choroid nucleus, and here again the septal vein. And now we just rotate the endoscope. We don't tilt it, we just rotate it backwards, and you see the choroid plexus. This is the thalamus, and this again is the choroidal vein running with the choroid plexus to the back. With the 45 degree endoscope, if you rotate that, you have even a better radar-like overview. So we look in the anterior direction. You see here the white structures is the corpus callosum, and the gray one is the head of the choroid nucleus. And then we rotate the endoscope 180 degrees backwards. You see the thalamus here, choroid plexus, choroidal vein. And this is the central part of the lateral ventricle, and here the choroid plexus goes to the temporal horn. Of course, with a rigid scope, you cannot follow it. For that, you need a flexible scope. Here's another view to the medial side. You see the septum pellucidum is completely gone. You see the choroid plexus of the contralateral ventricle because of this chronic hydrocephalus. So the foramen of Monro can look very different. This is the usual way. It's pretty good size. You see the fornix running here, septal vein, thalamostriate vein, choroid plexus, and you see the small colloid cyst. In the foramen, this was interesting. We removed this colloid cyst, and the ventricles became smaller, although there's not an absolute occlusion. This was very surprising to me because I thought there will be no change. But obviously, the CSF circulation and pulsation was already disturbed by the small cyst. You see there's a small foramen of Monro, and also the venous anatomy is very variable. Sometimes you have no thalamostriate vein, sometimes there's a very big one. You see this is a septal vein, this is a small foraminal vein. Very variable. This is a large foramen of Monro, choroid plexus running here, the fornix running here, thalamostriate vein, choroid plexus, and in the depths is the methintermedium, and this is already mammillary bodies visible. That's the floor of the third ventricle. Sometimes there is almost no foramen. This was a patient presenting with biventricular hydrocephalus, and both foramina of Monro were completely obstructed. You see a very atrophic choroid plexus, thalamostriate vein, septal vein. And this is also a case of chronic hydrocephalus. You see the fornix is very thin, running here backwards. This was a case where we did an ETV some years ago. So very variable is the anatomy. Now we come to the third ventricle. Again, 0-degree endoscope. We look to the floor of the third ventricle. What you see very nicely is the mammillary bodies on both sides. Here's the basilar tip shining through the translucent floor in this infundibular recess. Another patient, mammillary bodies, and you see this is very important. These are perforators. The perforators always go from the basilar bifurcation in a posterior direction. So even though this is the thinnest part of the floor, never do an ETV here, because when you inflate the balloon, you might rupture one of these perforators and can have a severe subarachnoid hemorrhage. Perforation should always be in front of the basilar artery, and this is infundibular recess. It's another patient. This is an ideal floor, very translucent. You see here, this is a clivus. This is the infundibular recess. This is a chiasm. Mammillary bodies, and what is that? That is a PCOM running very far medially. And here you see the oculomotor nerve shining through the floor. So this is an ideal case, and of course the best location for an ETV would be that space. Sometimes if you have a tumor, the anatomy is distorted. This is the infundibular recess here. And you see here, this is a medulloblastoma completely covering the floor of the third ventricle. Now we look with a 30-degree endoscope in an anterior direction. You see this infundibular recess. This is a chiasm, and this is A1 behind lamina terminalis. When we look back, we turn the endoscope 180 degrees. We look back, you see the aqueduct obstructed by a tectoglioma, and here you see posterior commissure. Now with a 45-degree endoscope, we see even better. You see lamina terminalis very nicely. Lamina terminalis is between the chiasm and the anterior commissure, which is up here. You see A1, and ACOM behind chiasm infundibular recess. And now we look to the left side, and this is the chiasm. Then you see here the contralateral fornix. This is the foramen of Monro on the contralateral side. And this structure here is the anterior commissure, and this is the ipsilateral fornix. So ipsilateral fornix, anterior commissure, lamina terminalis, chiasm. Again, endoscopic view, anterior direction, fornix, anterior commissure, lamina terminalis, A1, chiasm, infundibular recess, and ETB. This is a view to the posterior part of the third ventricle. You see an entrance into the aqueduct, posterior commissure. This is the pineal recess. You see here, this yellow structure is acervulus cerebri. This is the center of the brain. And here you see the roof of the third ventricle with the coroplexus and habenular commissure running here. So all can be seen very nicely with a 45-degree endoscope. When we look through the third ventriculostomy, we come to the prepontine space. You see this, our ETV. Usually it should be in midline, halfway between mammillary bodies and infundibular recess, just behind the clivus. And when we look in, after ETV, you should see the basilar artery. If there's arachnoid over it, then you are in a subdural space and it's not good. You have to open up the subarachnoid space and you see all the small perforators coming from the basila. Then we look with 30 degree in the anterior direction. What we see is the clivus, diaphragma celli, basilar artery. Then we look in the posterior direction. You see here the basilar, superior cerebellar artery, and here's one P1 and the other P1, and this is a bifurcation of the basilar. So this approach IPE is much better for clipping of an aneurysm than your approach. And when we go deeper down, we can see the clivus here, and you see that is abducens nerve. This is facial nerve, vestibulocochlear nerve, internal auditory canal, and here is the lower cranial nerve group, and this is an ICA. Usually you have not so much space in most cases, but sometimes you have a lot of space in the prepontine area and you can look at these structures. So we come with a 45-degree endoscope, and we look to the left side. You see the basila here, and you see the duplication of the superior cerebral artery, which is a very frequent finding. Also, when you do microvascular decompression, you frequently see that there's a double vessel. This is the oculomotor nerve, and this is the P1. Again, bifurcation of the basila, oculomotor nerve, superior cerebral artery. Then a view anterior direction, you see the thin diaphragma celli and the pituitary gland below the diaphragma. Now we are again in the prepontine area, and we see here is the abducens nerve coming from the brainstem. And here we look down to the inferior, the lower cranial nerve group with the jugular foramen. Now I show you a small video. This is a foramen of Monroe. This is a gray substance, head of the caudate nucleus. And now we just turn the endoscope. You see a thalamus striate vein. This is all thalamus, coroplexus, choroidal vein, and you see here moving the septum pellucidum. We turn it back. And then we can go in with an endoscope into the third ventricle. You see there's a fornix here, ipsilateral, chiasm, infundibular recess, lamina terminalis with the A1, and ACOM in front. Mammillary body, so we turn now the endoscope 180 degrees, so we don't tilt it. There's no damage to the brain. Don't think that we are doing sightseeing and damaging the brain. It's just rotation of the endoscope. And you see here's the entrance into the aqueduct. And we rotate it back and remove it. And then we come back with a 45-degree endoscope. You see head of the caudate nucleus. And with 45, really, you have a radar-like view. You see the caudate nucleus running here, thalamus striate vein, thalamus here, coroplexus, choroidal vein, septum pellucidum, moving And then we can, of course, not reach this area here because there is a flexible endoscope required. In Germany, we have the problem that it's not allowed for us to have chip on the tip flexible scopes in the brain because you cannot autoclave them, and the hygiene standards in Germany require that we have sterilization autoclavable endoscopes when we are going to the brain. That's a pity for us, so we have to use old fiber scopes or rigid scopes. Here again you see the lamina terminalis. Then we look back 180 degrees to the back, and you see the aqueduct. You see the big one is a posterior commissure, pinal recess, habenular commissure, and entrance into the aqueduct, and this is the roof of the third ventricle. It's another view in a suprasellar arachnoid cyst, and you see so nicely the basilar artery coming here, superior cerebellar artery, and this is a P1 segment. You see all the perforators coming from the basilar area. Very important to preserve them when you clip an aneurysm. You see the pituitary gland at the anterior lobe, posterior lobe. This is a carotid, and you see all the perforators from the PCOM. So it's very variable. On the other side, you will see the PCOM is very small. Sometimes you have a fetal origin and they are very large. But here you see the very small PCOM, but still there are important perforators which should be preserved. So the fourth ventricle, it's difficult to reach. Sometimes when the aqueduct is wide open, you can go in. You see this is a rhomboid fossa here. This is the cerebellum hemisphere. This is a vermis, and you see Luschke here, and Magendie. Usually they are occluded. That's why you have an isolated fourth ventricle, and then you can go in with an endoscope. Usually it's very small cavity. This is an old video. You see this an old fibroscope, what we used at that time in the isolated fourth ventricle. We go in. See, this is the vermis. And then you simply look for the choroid plexus, and when you follow the choroid plexus, it guides you to foramen of Luschke. But you see the optical quality is not so good. Here's Magendie. It's completely occluded. This is a rhomboid fossa, and here completely occluded foramen Magendie in the midline. So we can also come from the back to have another view into the third ventricle. This was after resection of the neurocytoma in the pinal region. And you see, when we look from here, you see the fornix running here. And this is the anterior commissure. This is now a 30-degree endoscope. You see very nicely anterior commissure, lamina terminalis, optic chiasm, infundibular recess, and this was our ETV, which we did before the surgery because he presented with hydrocephalus. So now some questions for you. What is this structure? Participants have to sell something. It's an interactive session.
I'm checking the chat, Henry. I'm checking it.
What?
I am checking the chat.
Can we answer, Henry?
Yes.
Okay, so that is the A1A1.
No.
Basilar tip.
This is basilar tip, mammillary bodies. This is P1 basilar tip. What is that?
Infundibular recess.
Exactly. And what is that? This is for the vascular guy eye.
Big P1 maybe.
It's a
Big
wick.
PCOM.
Like
PCOM. Yeah, this is a PCOM. Comes from the carotid, goes here to the P1. Very big one, but still you can make an ETV in a safe way.
I must say that everyone in the chat is responding properly. So they learned it.
That's good. What is this structure here?
Wow.
Same on this side, it's more easy. What is this?
Is it fornix?
Like the fornix.
Yeah. 3 points. Very good. What is this white structure running from fornix to fornix in this area?
Massa
Anterior
anterior commissure.
Anterior commissure, right. Sometimes really strange to see if you have this chronic hydrocephalus and just only the main fibers are remaining here, all other structures are destroyed.
Great picture.
Now here, what is this? Now we have these 3 levels. What is this structure?
Fornix.
Fornix,
Anterior
Anterior
commissure.
commissure.
anterior commissure,
Chiasm.
chiasm,
ETV.
ETV. Wow.
Too easy, Henry, too easy.
And last one, we look to the posterior part of the third ventricle. So what is this?
Habenula commissure.
Posterior commissure.
Which one?
Posterior commissure.
Posterior commissure.
Exactly. The big one is posterior commissure, is just above the aqueduct. What is this?
Pineal recess.
Spinal recess. Yes, sometimes you see these sand-like structures, which indicates that the pineal gland is not far away. This is
Habenula.
habenular
Habenula.
commissure. This is called suprapineal recess, and you see the coral plexus on the roof of the third ventricle. This is the ideal anatomy. What is this?
Pharisee.
Yes. What is this?
Fornix.
Massa
Thalamic
intermedia.
Is this one?
Massa intermedia.
Exactly. And this one?
Posterior
Posterior.
commissure.
Anterior.
This is fornicis, anterior commissure.
Anterior commissure.
Very good, very good. You passed all exams. Congratulations, my friends. Thank you
Send
for your
the
attention.
certificate. Send the certificate.
Henry, these guys were supposed to be experts, man.
Yes.
Henry, thank you so much. And
Well, Henry,
I must
Henry,
give,
let us answer. So,
yeah, I must give credit to everyone because everyone was correct in the chat. And
That's good.
we have many questions, Henry, but I chose only one of them. And Alu Sain is asking you if you always use, can you hear me, Henry?
Yes.
He's asking you if you always use 0-degree scope for ETV, and in case not, when do you use different angles? In which cases?
Yeah, these angulated endoscopes are just for inspection. So we look around, we look to the left, to the right, to see the anatomy better. And then for the ETV, of course, we have a working endoscope with a working channel, and this is only 6 degrees. Otherwise, you cannot look properly in the anterior direction. And then I always use a 30-degree endoscope to check the prepontine cistern to make sure that the basilar is exposed, and also want to see, is there any additional membranes? You know, the first layer is the floor, then we have the Lilliquist membrane, but frequently you have multiple membranes further down, and these should be open as well. Otherwise, you have not the pulsatile CSF flow, which is required that your CSF is, that your ETV is successful. But the 30-degree endoscope mainly is for the inspection of the prepontine space.
And we have one more question. How do you manage those patients which have small ventricles?
Oh, the question is it a good indication to make an endoscopic approach? So if I have a tumor in small ventricles, I usually do a transcallosal approach. If I have a patient with slit ventricles and he has problems with a shunt, then we will occlude the shunt, dilate the ventricles a little bit, and then we go in with neuronavigation. Sometimes we take biopsy from tumors in normal sized ventricles, not very narrow, normal size, and with navigation, it's a very safe procedure. But if you have slit ventricles, then I think the endoscope is not the best choice in many cases.
Great. So I must thank you again for taking your time. We knew that you were in the OR today and you were running back home to be with us. So we really thank you. We really appreciate it, Henry. Thank you so much.
I thank you for the invitation to contribute to your committee. Thanks.